Yeah, I'm really here to try to answer the board's and the committee's questions, right? Because I want to make sure this is the right fit for you guys. But yes, I am a geriatrician, physician by training, practice full-time, both in big hospital settings, also have my own private practice up through the tail end of the pandemic. And unfortunately, our little group of geriatric practice did not survive well through the pandemic. But along the ways of my career, I was also very engaged as part of informatics. So I was the medical director of informatics for Indiana University Health System. So I'm very into data technology platforms. And for the better part of my career was building technologies that were helping do the one-to-many type of work that we geriatricians and many other doctors need to do, right? Since there's so few of us, I was designing clinical decision support tools. This was before the days AI even was around. That tool was actually used during the pandemic by about 150 nursing homes, and all 150 nursing homes, and Dr. Ramani, and you'll be very proud of this, all 150 nursing homes had 30% less mortality during COVID than other nursing homes in the same district or zip code. And with 4 nurse practitioners and their laptop, we managed 1.7 million cases of nursing home cases. And that's the kind of background I have, right? I built scalable platforms that enable us as clinicians to do what we need to do. Of course, after the pandemic was over, and like I said earlier, unfortunately, my little group didn't survive. So we had partners that left, retired, took a sabbatical. It was just a very stressful time, right? Obviously for folks, and they had to do what they need to do. I was thinking about restarting my practice. And of course, at that time, I started talking to other doctors, and this issue came across, which what I experienced too is, for the most part, independent practices are not large businesses. Even when we get to 100 employees, in the eyes of, quite frankly, everybody else, we're still a small shop, right, in terms of a business, which makes it very difficult for us to get health benefits, not only for ourselves and our family, but also try to have good benefit packages that can attract new partners, new employees, right, or new staff for our practice. So this wasn't just what I experienced. This is what a lot of my colleagues experienced. This was across multiple specialties, right? It didn't matter if you were a large dialysis group with 120 employees in Dallas, or you were a 19, employee physician practice in New Jersey, or you were like me, like 5 physicians and 2 nurses, right, in Indiana. That we all experienced the same issue. So as I started looking at this, I said, well, why are other industries not necessarily struggling with this, right? Why are trucking corporations with only 10 employees not having to deal with this? How come manufacturers with only 30 employees don't have to deal with this? Well, how do they do it differently? And this is where we learned about the different types of health models, right, are available to employers. So self-funded, level-funded type of things. So with that, I'll just kind of go through my screen a little bit. So this is who we are. So when I decided to build Ryze 3 years ago, I learned from the other industry, and I looked and see if we had one for ourselves in our medical industry. And the answer is I couldn't find one. So after looking fruitlessly for about 1.5 years, I said it's time for me to try to build it, right? So that's what RyzeHealth is. We are a health insurance solution company, and we design exclusively for physicians. That means MDs and DOs. We hope to expand to PAs and NPs in the near future, as well as like dental and other, even like chiropractor or other type of medical professionals that provide care in the private setting. But for now, what we are focused on is the physicians who have MDs and DOs and own businesses. We're trying to help them first, okay? We are, in a sense, a private insurance, right? When people say, what's the difference? We're not government funded. We're not susceptible to the ups and downs of CMS regulations, right? This is a private health insurance. And what we're really aiming to do, like I said, is help with the over 400,000 independent physician-owned practices in America, tailoring our insurance plan that meet their particular professional needs, their particular right type of employee needs as well. And what we operate at is a group captive. You may have heard of those before. That's how all these other industries have set up. They set up health captive organizations. Then through that organization, they're able to fund, right, and cap their risk financially and be able to help insure smaller employers. So when you join as a small employer into that group, they're taking on some of the risk of your health benefit or insurance when that happens, right? Because otherwise, you as an employer has only 2 choices. You can either go with fully insured products like in the marketplace, like Blue Cross Blue Shield, or you can try, if you're a really wealthy, big group, you can self-fund, right? So we do have that option for groups that are very big. We can help them create their own self-funded plans, and we can still be a risk of taking off some of their catastrophic claims, right, off of their self-funded plans. But a lot of employers, medical practices are small, right? Less than 10 employees. They don't have the money to start a self-funded plan. And that's where we offer what's called a level funded solution, where we're essentially functioning like your Blue Cross Blue Shield, right? We're taking on the majority of the risk beyond anything that is your premium, right? So you only pay your monthly premium, and we're taking on the rest of the risk beyond that. And that's how a lot of these employers have created their solutions. I can give like an hour talk on how this works, and I'm happy to answer any questions around that. But this is kind of just like the bullet point of what RyzeHealth really is underneath. I'll just pause here to see if there's any questions from the folks on the call. Okay, and I'm happy to come back to explain more of this. Okay, so now even though we're private, that does and because you go private, you're able to cut out a lot of the extraneous regulatory or even just like business decisions that bigger payers have, right? So we can cut out a lot of brokers, a lot of middlemen. We can cut out a lot of the processes that you may have to meet when you were taking CMS dollars. Since we're not, we don't have to worry about those. So that allows us to bring our premiums and our costs down. But that doesn't mean that we're not offering a comprehensive product. In fact, when we do a comparative study across the United States, our products in every single state is basically the equivalent of your gold and platinum PPO plans in your state marketplace, right? So whether it is healthcare.gov or your state has its own marketplace of insurance products, we compare very, very well, usually competitively with gold and platinum level PPO plans. So that means, yes, we do cover urgent care, emergency care, hospital stays, procedures, outpatient care, preventative care, right? We even include in there, because again, this is our own health plan. We know physicians are busy. We try to incorporate things that are more conducive to like us as consumers of health, right? We're busy, so we don't always go taking days off, running off to doctor's offices, right? We tend to leverage telehealth if we could, right? We tend to be very medically educated, so we tend to self-diagnose a lot. So we need access to these care, but we don't necessarily use the care in the same way that a average American consumer may have, right? So us being our own health plan allow us to not only cut costs, but allow us to really design a health plan solution that is more conducive to a physician's career. As other examples, for when we designed our health plan, we took into account, well, what if you were a direct primary care physician working by yourself? What if you were doing locums, right? You don't even have practice. What if you are doing full telemedicine? Or what if you are like right in between, like you have some jobs at the hospital, but you also have your own practice, and that's where you need some insurance. Like, how do we take into account the various different ways that physicians can practice these days, right? So it's a very unique program that is not the same as what you would get from Blue Cross Blue Shield. This is a little bit more of a big read, but some things that really make us different is because I don't like the idea, right, of in-network, out-of-network, right? So a lot of times when you look at the data, even though how do I say this? So even though if you know how there's the biggest fear you have as a consumer of health insurance is if you happen to be out-of-network, right? Because that means that you can't access that physician, or if you're in an emergency situation, you end up in an ER or hospital that's out of network, you're eating 50% of the payment of that, right? So when we designed our health plan, we really tried very hard to say, how do we minimize the possibility of one of our physicians or their families or their employees being in an out-of-network situation where they end up with that cost, right? So the way we do that is by twofolds. Number one, on the acute care setting side, right, we don't have the ability to contract every single hospital, but we could piggyback, if you will, off of Blue Cross Blue Shield and Cigna. Those are our two partners, right? So when we're not selling their insurance plan, all we're doing is piggybacking off of the contracts they've had with the hospitals and pharmacies and rehab centers in your area. So when you present Ryze's card, right, even though the hospital or ER may not have heard of Ryze, when they put in the payer ID, it will pop up as Blue Cross or Cigna, depending on which one is the bigger dominant player in your state. So when physicians say, if I go to this hospital, will they take Ryze? The answer is, if they take a Blue Cross Blue Shield in your state, it will be covered, right? It'll be the same. We're paying at the same rate that Blue Cross Blue Shield has negotiated with that hospital, so your care will be covered in that area. What's really innovative for us, though, is that because we are a insurance for physicians, right? On the outpatient side is where we are very unique. So imagine it this way, right? So I come to you, Dr. Manian, just to use you as an example, right? You have a practice. Not only do I want to ensure you and your family and your employees, I would want your practice to be on my network. Why? Because I can pay better, right? I'm a self-funded plan. I'm a private insurance. So we pay not 70%, 80%, 100% Medicare rate. We pay 120 to 150 to 200% Medicare rate, right, for our private physicians. Whereas with big payers, they kind of do the reverse. They pay hospitals 500% Medicare rate, and then they pay like, private practice less than that, right? So because we really want to be the platform for independent practices, especially in the outpatient setting, for the members who join us, we actually ask them if they could also service our health plan, right, to be a part of our network. And in that way, we can include every single physician. So when you come on board, Dr. Mania, like if your wife has an OB physician she's used to going to, if your kids have a pediatrician they used to go to, right? We actually want them. This is not where you join us and then you have to find in our network which physicians or which practices are in network. If they're not in network, we want them in our network because we want them to be a part of our community. And if they need insurance, yeah, sure, we'll be there for them on that part too. Okay, so this is how we're actually expanding access significantly beyond traditional health plans, whereas they might restrict themselves to a certain number of doctors in the area. We're not. We're absolutely open to contracting with every single one of your care physicians and your team. I'll pause here too, because sometimes folks have questions around this as well.
Yeah, I think one of the things that was enlightening to me when we were first talking about this is there are two distinct parts to this, like you said. Having the insurance for yourself and your family in the office there, so getting the health insurance, and then also being a physician that participates in that network. And they're two independent. You don't have to have both. You can do one or the other.
That's right.
And the reason to consider or entertain being on the Ryze panel is your pay is typically above what the Blues pay.
Yep.
More than Highmark or Capital or whoever else that we have in our area. You mentioned Aetna as well.
Mm-hmm.
I don't know if you can give a rough estimate about how much above, the typical physician fee schedule you might end up.
Yeah. So we do, like I said, usually we will use. There are other companies like Turquoise and Hack that provide kind of a market rate of your area, right? And I know you guys are a clinically integrated network, so you may have your own fee schedule. We're happy to take a look at that and say, if we want to contract your entire network, which I think makes a lot of sense, right? You guys are already a network of multi-specialties taking care of other payers. In that perspective, we're coming in as Ryze saying, we would love to have your network as a provider group servicing any patients we may have in the area. Now, funny thing is those patients or patient members may actually be your other colleagues, employees, or their family members, right? So instead of paying through Blue Cross, which you getting an insurance with Blue Cross, paying them separately, and then you are also a provider for Blue Cross, getting payment from them. You're with Ryze, you're both, right? You can be both, and be able to take care of your colleagues, employees, and their families just through our platform, right? So that's the unique part. And yes, you would not need to be. You don't, if you're a provider and you want to join the Ryze network purely as a provider site, you don't have to necessarily take our insurance, right? If you have better options, or if you're covered through your spouse and their employer is paying 100% for that, don't take ours, right? You're getting it for free through his or her coverage, so you don't have to worry about that. As far as how well do we pay above that? Usually we will negotiate to pay above whatever rate that Medicare has paid in your area. Now, you guys are already a clinically integrated network, so you guys may already be getting better pays than that. Happy to work with you on that. And that's all I can say is that we want to be very flexible because we would love to integrate, have a network like yours in Pennsylvania.
Great.
Yeah, but like I said, typically, if we're working with just a practice, if it's internal medicines or family medicine specialties, it's usually 125%, like it's 120% to 150% Medicare rate. If you're like a subspecialty, we're usually paying somewhere from 150 to 180. If you're surgical subspecialties where you have ambulatory centers, we're usually like 200%. That's usually where we pay in other states. Being perfectly transparent, we haven't entered into Pennsylvania. We would love to. We are able to go nationally, but since this is a relatively young insurance company, if you will. I can tell you I'm not in Alaska or Hawaii, right? Even though we could provide insurance coverage in that area, we haven't had any customers in that area or providers in our network in that area that we've contracted with yet. I would love to contract with your organization, and happy to have that conversation with you, Dr. PACN. Okay. So the other thing that I try to emphasize is that we're really less of an insurance. That may have been how we started, is the desire to create an insurance company because we needed an insurance product, right, for independent physicians. But as we were building our company, we realized that there was a lot of interesting opportunities besides health insurance that we can offer to independent physicians. So as an example, right, so this is RyzeHealth insurance. That's like, hey, if you joined our provider network and you're servicing Ryze, you could also get our insurance for yourself and your employees. But we also, as we were forming our health plan, we started getting some pretty amazing prices, right, as you might not have expected insurers get from specialty pharmacies, right? So we were able to create, we were getting prices that were closer to what we used to see as 340B plan type of pricing for specialty meds. These are infusion medications used for GI, rheumatology, conditions. These are your GLP-1s, right, that people usually sometimes don't even get covered. So we were getting out some pretty amazing pricing, and we thought, well, why only have that pricing for Ryze and our insured members? Why can't I create a possibility for, if you just have a practice and you want to access the same pricing that we have as an insurance company to these specialty medications, why can't I do that? And the answer is we can't. So we did create that. And I'm happy to show you guys a little bit of what that looks like on our portal. But we can integrate these type of additional benefits to your network, right, for your physician members. So if they join and say, we need insurance, great. If they say we don't need insurance, no problem. But if they are looking to, let's say they have a unique contract with, or you guys have a unique contract with an ACO where you're controlling the cost of the medication spend would be important to hitting your deliverables, right, or your medical loss ratios. We are signing up some other networks in other states where they're under that. So by being a part of Ryze, even though they're not necessarily there for the health insurance that we're offering, they're taking advantage of our specialty pharmacy medication program so that their physicians can access cheaper infusions that is better for their buy and bill, or just, again, if they have a value-based type of model arrangement with their local systems, they're able to access cheaper medications for taking care of their patients. So as an example, we're getting ready to do one in North Carolina. It's mostly family medicine doctors, but they have a unique contract with Humana, where they have to keep between, lower the medical loss ratio to like 85% or less, right? But as family medicine doctors, one of their problems is they say, well, we have a lot of patients who are we do have to send them to specialists for GI infusions or rheumatology related conditions that require infusions, and it's about like 7%, right, of our patients that need to do that. Now, even though we're the ones under the value-based, we have to send those patients to these specialists, but they're not under value-based. So if they end up buying medications that are more expensive, it ends up coming back to our contract, right? So in that sense, they're using Ryze more for our specialty medication pharmacy, actually, because they want to help the specialists they refer to say, hey, buy from here, and we'll be able to lower the cost of the medication. We'll share in that savings together, and that's a very unique arrangement that we're doing. So all I'm saying is there's just more that Ryze is looking to offer. We're not just trying to be an insurance company. We're really trying to see what other value add we can bring to our members. And yes, we also know a lot of physicians are, if you're independent, you don't have a 401k, right? You make your salary, you got to figure out how to invest it very wisely. We have a partnership with a company called Passive Income MD. It was founded by physicians. These physicians are mostly independent practices. Not only do they share coaching on how to build a very successful practice, but they also are able to teach physicians on how to invest, right? So they teach you how to invest in mineral rights and land trust and short-term rentals, right? Like things that sometimes we as physicians don't necessarily think about immediately, but are getting our own financial well-being and investing our own hard-earned money wisely is something that we can learn from other colleagues as well. So that's also a program that we're launching with them in September of this year. Okay. We are building traction. So there's when we started this, we thought only small medical practice would be interested in us. We actually have very large medical groups that are also looking at us as well. There's 3 in particular out of South California, Missouri, and Texas. And those 3 added together have about 2,600 employees. And these are large medical groups, right? But they still struggle with the same thing where they can't get good coverage that doesn't just go up by double digits in premium every single year. So they're looking to join our captive to leverage our level funded and self-funded plan options so they can lower the cost of their employee benefit spend while still getting great coverage for themselves. There's also now that number, this is a number I gave you about 2 months ago. It's now much higher than that. So there's about 140 practices now. These are the smaller practices between 10 to 70 employees that are registered and looking for when we go live, for example, in Alaska or Hawaii, then or Georgia, then these are the practices that we'll be bringing onto our ecosystem as well. And of course, we partner quite a bit with medical society. So we partner with Charleston Medical Society, then South Carolina Academy of Family Physicians, Medical Society of New York, Rheumatology Private Practice Alliance. We now have another Osteopathic Medical Society of Arizona, as well as Tennessee and Georgia that are in conversations to have us be a kind of a member benefit, right, for their society. So when you join these medical societies, you can also access what Ryze has to offer, whether it be health insurance, specialty med program, financial, financial coaching programs. These are all benefits that they're looking to add on for their members. So that's basically my short presentation. I know you guys have questions, and I would love to figure out with you as a unique organization, right? You guys are independent doctors, but you're also functioning under value-based contracts as a clinically integrated network. How can we help? How can we be of value to your physicians? How can we be attractive, right? How can we be an attraction for you as you look to bring in more partners in the state of Pennsylvania?
So, quick question to wrap it up. How many lives are you covering today, and when did you start covering these lives?
Yeah, we really started building this about 3 years ago. It was really only this past year that we decided to make it more national, meaning that we, as a health captive, we were only looking to service some of the practices in New York. Actually, that's kind of the origin story. Is I met Dr. Lisa Ang. She had an IPA out in New York. It was growing, and this was one of the big ask from the IPA's physicians, right? So originally we were building this mostly for the now there's about 100 providers in the New York IPA. Those are the ones that we are bringing on board. But as we started to grow, word got out to New Jersey. I know Dr. Pagan, you met Dr. Ang as well, and that's why we're starting to spread. So in terms of the number of lives, we're looking at about 2,000 lives that will be on our, or 2,000, right? If you're talking about employee families, there'll be 2,000 employee families that are on our platform by the end of the year. Dr. Warda said she can't hear me. Is everybody else able to hear me? Okay.
It's a unique problem. I guess he's not. Keith, if you could message Dr. Warda just saying that it's just him, that everybody else is actually experiencing. Dr. Ramani, and during the committee meeting, you actually came up with I thought, an excellent, but possibly tough question too, was in terms of stability or financial rating. Does something like that exist, Michael, for RyzeHealth, or is it still too new?
We're still too new for that. And those ratings are usually for like government funded, like the bigger, fully funded insurer programs. It may be my connection. So if it is my connection, please pardon me. I do live out in the suburbs. So apologies about that. But no, we don't have a rating. Most self-funded plans don't have a rating because if you think about Microsoft, Amazon, right, even big hospital systems, right, big hospital systems have their own self-funded plans, very similar to what we're publishing here, except for small independent practices. So there's no rating options for them. I think there was a question about like how do we compare rates wise? Like usually in most states that we're in, again, we collect the publicly available data to see how their plans compare to ours. We're usually premium wise about the same, if not lower by anywhere from 10 to 30%, depending on the state. for our again, like our gold or platinum level comparative plans for the market.
So if you have a relatively small number of lives covered, you need a big reinsurance in order to, all it takes is a couple of catastrophic cases.
And we have those. Yep. So you're right. Yeah, we as just like anybody else who said, again, we're not, I have to say, like, the newness of RyzeHealth isn't in the business model. It's just in the business focus, right? Again, if somebody else had built this for physicians and was available, I wouldn't be building this. Right? But the health captive as a insurance model has been around for over, I would say, almost 20 years now. More and more employers are moving to that, but it used to be you had to be a pretty big size employer like your hospital with thousands of employees to make it financially make sense. As the model evolved, smaller businesses, like maybe a couple hundred employees, banded together so they look like they have 10,000 employees under a captive and created this. But nobody's really gone down to the level where we are, because we're not, right? 50 employees, we're 5, we're 10, we're 15, right? Like that. So nobody's ever created a captive with a plan to cover that level. So, but you're right, Dr. Ramanian, is that when we created this, we also had to use the exact same firms to create our health plan. So we had to use, for example, Milliman. Milliman is the largest underwriter, right? They're the guys that financially analyze whether a health plan can survive based on their charges and their potential costs, right? They are the ones doing all the work every single year for the big 5 payers. We paid a couple $100,000 for them to design and look at the data to say, can we do this for small medical practices, right? And we had to submit a feasibility study to the state of Tennessee, where we are domiciled and got our captive license. We had to submit it to the state regulator to say, this is an analysis, this is how much money we need to have, this is the type of reinsurance coverage we need to have in order for this to survive like 10 years, right? So we had to do the same, everything that we had to do is very similar to what big payers had to do in order to get their licensure and to be sustainable financially. But yeah, just because we're new doesn't mean that we don't have reinsurance. And unfortunately, like I said, through my entrepreneurial work in the past, I've also had connection with several family offices, right? And these are family offices who have an aspiration to help protect what they feel is the backbone of America's health, which is independent practices, right? They feel that that is where you can increase patient choice. That is where they don't like necessarily seeing the consolidation of healthcare into only a couple of large systems in every single state. So they're the ones that are backing us financially at Ryze to be a health captive. And on top of that, like I said, we have our reinsurance partners, so that no, one catastrophic bill isn't going to destroy us in any sense of the word.
So excuse my ignorance. I'm not familiar with the business end of your setup, but there is really still no guarantee that RyzeHealth can go out of business in 2 years or next year or something like that, close doors, and people will have to then go through the exchange and deal with all the headache, even though we grandfathered in auto exchange every year, and we're renewing our insurances for somebody else that way and keeping it simpler and cheaper. Am I correct, or is there some sort of guarantee that no, we're backed by Blues, so if RyzeHealth goes out of business, the Blues guarantee to cover you at the same rate, etc., for this many years? Is there such a thing, or no?
So let me kind of maybe reframe that a little bit. I think it's a misconception to even think the Blues are for sure there forever and ever, right? Even Cigna sold their medical business, the Medicare business recently. So, right, so there's no guarantee of that. What I think what you're saying is, financially, can we sustain the addition of members and so forth? And what I'm saying is that, much like the Blues, we have to make sure that we have a certain level of tens of millions of dollars, right, to even be a captive. And that is just so that we can then show the reinsurers, the same reinsurers that would reinsure Blue Cross, because don't think Blue Cross don't have their own reinsurance. They use bigger ones like Berkshire Hathaway, Pan America, Swiss Reinsurance, right? They have even bigger reinsurers that insure them so that if they had a catastrophic year, they're covering that. So we're doing the exact same models. And these are for example, our reinsurers are publicly traded, right? Corporations. They're not small, couple $100 million. They're multi-billion-dollar types of corporations that are reinsure us. Reinsurance is also a very dirty business. I'll tell you that. Like a big chunk of what we collect as premiums goes to reinsurance, right? Why? Because, well, you can't do without them. I mean, I don't have billions and billions of dollars just store away. So we need billions and billions of dollars from these reinsurance entities to say, all right, we're paying you handsomely. If our house burns down, you are there to help us rebuild it, right? And that's a big part of the business of creating this health captive.
Yeah, but I remember years ago.
Yep.
There were people in Texas, I think 40,000 lives or something like that in that range, that were insured by entity, and the entity in middle year basically went flat and closed doors. These people were stuck with the bills, and their physicians and the hospitals, etc., all went unpaid and so on. I'm wondering, does the state you're licensed in has any kind of setup guarantee that that's not going to happen, that there's a backup system that you have to present that, hey, we're going to cover them for the whole year at least, or thereafter, or no? And that's where I'm really naive, and I don't know if there's such thing or no.
There isn't really a such thing. A lot of times when you hear these self-funded plans go under is that they didn't cap, just like anything else. Like you can't start a business without enough money, right, for the rainy days. You have to. So we, for example, looked at our financial model. For example, we raised enough money that if we were losing 30% every year for the next 5 years, we would still be around, right? Like that's how much we plan, right? There are, I don't want to talk badly of what's happened in the market, but it has happened. So for example, when we talk to the state of Tennessee regulators, they're very strict on who they give a license to. They said, because there are people who came in and they just want to start a captive, and they're really just trying to be a broker, and they start with $100,000 in their captive. We started with 10 and it's growing, right? Like we start with 10 million and it's growing, right? So we're capitalizing this captive like correctly so that it becomes sustainable. And it's very much the same as when Mayo started their own health plan. Mayo does have their own health plan, right? That's why you work for Mayo. When you work for Mayo as an employee, you'll see, for example, they have the Mayo network. Well, where'd that come from? Well, you are a big healthcare system. So you can create a health plan where if your employees are just using the Mayo network, whether it's an outpatient doctor or their own hospital, there's a plan for that. Then they have the extended network, right, which is Mayo's extended partners. Maybe they have a contract with, for example, you guys in Pennsylvania. And so if one of your employees was being seen by Pennsylvania Clinical Network, they pay a different rate, right? That's what you would negotiate with the Mayo's self-funded insurance plan. And then they have the real out of network, which is like, okay, if you're in like Cayman Islands for vacation, you got really sick there, that's really out of network, right? But they kind of do the same thing. But again, this is a big employer that are able to do that. And when I created Health, I was like, well, why can't we do that if we have 400,000 independent doctors? That's actually, if you band us all together, we're larger than any medical entity, really, around the country. So why can't we create a similar group or similar financial model where if the group was being careful within the network, just like Mayo's employees are being careful within the Mayo network, why can't we have the same low-level copay, like low copays and great coverage? So the financial model was easy to study and replicate. And then we took all I can assure you is that we had to raise a lot of money, right, in order to capitalize this the right way, so that it isn't just a play to like make money from insurance. This is really an infrastructure that we're creating for independent doctors.
Who does your pre-authorization and the dirty work, so to speak?
Yeah.
You contract it through some entity like NIA or other places, or you do it yourself, or who does that?
No, right now we do have partners around pre-authorization and claims processing. That technology takes a while to build. I do plan on building that internally at some point. Again, I'm a technology guy, so I will eventually create those internal platforms so I can cut out the cost of having to outsource that. We have a very good partner called Covet. Covet is a third-party administrator, right? And they are a very young TPA. So a lot of the older TPAs are not very automation driven. So you can see prior authorization times take up to weeks. Our prior authorization is usually like 48 hours, and we have a less than 1% denial rate for prior authorization right now because of them as a young TPA building the right technology platform that we can interface with as an insurance company to make sure that process is very clean, right? Same thing with their reimbursement, especially if it's our own health plan. So if your employee saw somebody else, right, in your own network for, say, delivery, labor care, right? That payment is like within 48 hours. So that's the kind of the beauty of having your own internal infrastructure. That's technology driven.
And what's your philosophy regarding physicians ordering tests for themselves? Is there guidelines, rules that you guys have? Some
we have not made any rules. I hope to not have to make it.
Yeah.
Yeah.
I mean, we're part of Highmark, and I don't know Highmark. The way my staff says, "Oh, you're special with Highmark, so you don't need authorization for any of your patients." So it's easy for me to order stuff, and they don't give us hard time. There's some insurances that basically say, "No, you can't order stuff for your family or yourself, etc." And
we don't have that rule right now. Yep.
Yeah.
Yep. We don't have that rule. Yeah, you could order stuff for yourself. You can order stuff for your family. In fact, we kind of count on that. Being not brown nosing you. I mean, yes, I am a physician, so maybe I am a little biased, right? But why would you not let the most medically educated people take care of themselves? That's like saying your car mechanic's not allowed to fix your own brakes.
Yeah.
Right. In fact, that's how you do lower the cost. That's why when I looked at the data, I know insurance companies like to say that physicians are high utilizers. We're not. If you really look at the data, we're not the high utilizers. Maybe the family member of one of our employees, maybe. That does happen, right? Statistically, there will be somebody with multiple myeloma, hemophilia, right? You hire enough people, you will have somebody with it, but it's usually not the physicians that are the high utilizers, right? And there's very good social determinants of health data studies to show why that is. And we already all know that if you are more medical, like higher medical or higher education in general is better health, right? Higher salary is better health because we're not the ones that are trying to figure out if we should buy this med or not. Fine, $15 antibiotics, I'll pay for it. Don't care, right? Like, so it's actually, we're depending. This is why we only focus on physicians right now. And again, I love my mid-level colleagues. There's a reason we don't have the data yet to say that, oh, hey, do NPs and PAs, even though, again, their medical training are starting to hopefully, start to match what we're doing, what we've gone through. Do their health outcomes rival that of physicians? I don't have the data on that yet. Most of the data is not as telling for that, right? So I hate to say it, this is why for Ryze, we're like, no, we're going to focus on MDs and DOs. It's not to be elitist. It's not that. It's data driven. Like MDs and DOs, if you look at their health outcomes and the way they consume healthcare, it is very different from the average consumer. It is very different from even your clinical folks, right? Like like nurses and others, right? Or techs. So we're actually banking on the fact that because our patient members are physicians, they're actually going to have lower cost for the entire community as a whole. That is not to say we don't want to give you. That's why we made sure that if a physician said, I need this, I'm like, you better make sure 99% of prior authorizations are done like this, because I don't want to challenge that right at all, right? Like right, I don't want to challenge. I want, if there's a group I want to give free reins to access healthcare systems, it's this particular community.
And how does your rate compare to average, let's say Blues or other insurances in your areas that you're marketing?
Yeah, I don't have exact numbers. All I know is that from our TPA, they're saying like we're paying like whatever is the rate of Medicare in that area, we're paying like 120+%.
No, I mean the charge for insurance for
yeah. So we don't have anything in Pennsylvania because we haven't launched with anybody in Pennsylvania yet. When we were looking at we actually downloaded some of your place data plans. Sorry, it does say my connection's low, but hear me okay?
Yeah.
Okay, let me stop sharing my screen, and maybe that'll help with my bandwidth a little bit. But when we looked at the Pennsylvania plan, so basically, if you have a lot of family, like if you're a family of 4, our plans are basically about 10% cheaper. If you're looking at both premiums as well as like all costs out of pocket, like for the year, we're usually about 10% cheaper. Now it actually goes up when you have a bigger family. Like for a family of 7, our premiums is like almost 20% cheaper, and your total out of pocket, whether it's deductible or no deductible or not, we're like almost 25% lower than what you guys are getting from the marketplace, so to speak, in Pennsylvania. Now that's only obviously we don't have access to every type of potential plan you might get from, say, Blue Cross. They may have more data that their brokers sell you, right? Like it's kind of like travel agents. They have special packages that we don't know about that isn't very obvious out there. But for the ones that are available out there, we're very competitive as far as we can tell right now.
And you can insure as few as one person in a practice, or is
Yes.
there minimum? You have to be called a group, so to speak.
So right now, it's easy for us to insure like a single physician, right? So if it's just you and saying, hey, I'm not even sure I'm going to offer it to my employees yet, we can cover physicians, like single physicians, no problem. Group size wise, right now, that is dependent on our reinsurer, right? So as you said earlier, like how would you cover us if it was bigger? Reinsurers may have different rules. So when we get a group, we have to figure out which one of the reinsurance partners we have are willing to go down to that level, right? So if you have a group of 50 or higher, those are usually not a problem with any of the reinsurers. If it's 25, there's a couple that are where they like that type of employer size. And then below that is usually when we start to have a little bit more trouble finding the right reinsurers, because we'll accept you, but it's just who will reinsure us, right? If you're a very small group, how do we have reinsurance on top of that? There are a few more partners that are coming through on that, but right now I would say we could cover individual physicians just fine. And then for groups that are like less than 10 or 15 is where we may have it may take some time for us to figure out how to help those groups in particular.
So if you have a practice with, let's say, 2 physicians in a practice and 2 nurses and no families wanting to join, and the group would be 4, that would be difficult at this point.
That would be a little bit difficult at this point, but what we are working on is a couple of things, right? So we have had a couple of that scenarios already come up where the advice we would give those particular groups is say, well, we can insure the physicians, no problem, right? Like you 2 partners can join individually or insure you, no problem. Your nurses are the ones that we can't insure, right? Unless your practice was big enough. But this is where, as you guys have heard, even with other employers, they say, okay, well, we'll just give a stipend, right? So that my staff or my employees can still shop for insurances on the marketplace until such time Ryze is able to offer that, right? And so we are working towards it. It's just we can't be everything at once. We are not Blue Cross, so we don't have the ability to just randomly change up our products in the market as quickly, right? But what I will say is that we don't have any trouble with physicians individually. So a lot of our initial physicians are physicians who are, practice of 1 or locums, right? Those are the type of physicians that we take on initially. And then there are some very large groups that are coming on. And the ones that are 10 to 70 are the ones where we're starting to be able to bring on in certain states. Certain states, again, it depends on the reinsurer, they're more comfortable with based on the cost of those states. I think Pennsylvania is actually relatively okay. Like New York was actually really hard, right? Like New York, actually, a lot of reinsurance companies are like, hey, Mike, unless that doctor has 100 employees, I can't reinsure you, literally. Like, right? So even if you have 70 employees, we had one doctor who was a very successful ophthalmologist. He has a building in downtown Manhattan, 70 employees, and he wouldn't qualify. He wouldn't be able. We couldn't help him, right? Because the reinsurance won't help us, right? Cover for him, but we wanted to. We are looking. There are other reinsurers. It's a very interesting market right now, doctor, where other reinsurance companies are entering the game. Just like how when there used to be only a couple of PBMs, right? And then PBM got blown up by news about rebates, and now there's a bunch of new PBMs coming in that are more price transparent and so forth. Same thing with TPAs. There used to be only a few, and they rake employers over with what they charge for prior authorizations and claims processing. Then younger companies came out, and now there's more selection. So I think the reinsurance market is going through that right now. Believe it or not, I'm talking to Allstate and Nationwide. these are not companies that they were like, wait, car insurance, right? Like Geico, like they're getting into the game, right, into reinsurance. So there will be more players coming into that market that gives us more of a selection of partners that we can use in different states to help with the smaller employers.
And are you guys going to be offering any kind of Medigap or Medicare related programs, or?
Not at this time. It's a little bit harder to navigate into the Medicare insurance world. As you can imagine, the regulations and the licensure required for that is more than just private health insurance. Those start getting to federal regulations, where right now as a health captive, you're regulated at the state level. So we have to meet Pennsylvania state regulation, Florida's regulation, which are usually about the same, quite honestly, right, with subtle differences. To get into the Medicare, Medigap, COBRA world would be different. We are actually working on COBRA soon, so we should be able to offer COBRA for our employers, so that if they had an employee that leave, we can actually offer them COBRA through us. But that's probably as far as we can get for the year 2025. I'll keep working on it, but yeah, so far Medicare is not in the scope.
And if I'm correct, the states don't consider clinically integrated practices or physicians as one practice. They're still individual practices that have to meet the number, right?
I would love to work with you guys on that. There are loopholes. I don't like using the word loophole because it sounds like, well, if the regulation can close the loophole, then it's not quite like that. So one I shared with Dr. Pagan when we talked about this, right? I'm like, well, actually, and this isn't a PEO. I know you guys have heard of PEOs like ADP, Source, right? Like this is not a PEO. So we're not talking about co-employment, right? But this is actually something we did a really strong, like spend quite a money on lawyers to figure out. But if you work 8 hours a month for an organization and they pay you a payroll, not a invoice, right? They pay you a payroll, they pay the state tax, social security tax, they even pay a W-2 tax on that. Even if you only worked 8 hours for that company, and you would count as a W-2 of that entity, okay? And in that scenario, you could actually have, so as an example, I'm not saying we should do this without some legal counsel, but let's say all the physicians of the Pennsylvania Clinical Network said, you know what, we'll all work 8 hours a month for some sort of entity, right, under the Pennsylvania Clinical Network. And we're getting a small paycheck, right, through that. Then technically that entity would have potentially hundreds of you as employees, and you would qualify, right, for, like, more easily qualify for the reinsurers to help us insure you, right? So that is, for example, a loophole that in some of the states we are leveraging, if we can swing that. I know that I don't want to complicate your organization, right? And I know that medical societies, for example, can't do that at all, right? They're just like, hey, we're nonprofit, we don't really do any of this. That's where we have plans, where Ryze has plans to create additional physician groups, right? We don't want to compete with what you guys are doing, but if we had to create a physician group, so to speak, where everybody works for that for just 8 hours a month, just so that we can offer this insurance to the physicians of that, we will do so. It sounds, I know some physicians said that sounds like a PEO, but I'm like, yeah, but it's not. It's a little bit different than PEOs, where they're like, we clearly are a separate entity and we're doing some sort of co-employment model. There's a different set of IRS rules they abide by. I apologize. I'm not going to be able to give very detailed discussions because with being respectful of your evenings, all of these questions you have, doctor, are excellent. It takes hours to explain. What we
that wouldn't work for the staff then, would it?
You can. So, like, for example, one of our clients, hopefully soon to be clients in South California, they have physicians hired into one entity and all of their staff hired into another entity. Okay. And in that scenario, it is only for Ryze, it's just a business decision for us then, right? We said we only insure physicians. Well, your other entities are all the staff that are non-physicians supporting your physicians. Would Ryze like to insure that? We could. It's a conversation we're having with their CEO because they have 600 employees in that entity, right? As I share with you, I'm like, yeah, but non-physicians tend to utilize the systems a little bit more sporadically, so their cost factors are a little bit different. So we would have to come up with a different type of plan for them that we're willing to insure But as far as reinsurance go, the reinsurance company is happy to insure like 600 employees, right? But we would not be able to offer the same type of insurance that we gave to the physician group. So they have about like, it was like 80 physicians, and then like I said, almost like 600 other employees of back office and other stuff. They also have an MSO, right? So there's other things they do there. But
is that federally acceptable for writing up as part of your corporation expense? If you have
Yes.
two different, okay.
Yeah, you can. Yep, you can. Yep.
Thank you.
No problem. Appreciate your questions. Thank you.
Yeah, we're coming up on time here. I think they were excellent questions, and each time I listen to you, Michael, I learn a little bit more in this 8-employee thing or 8 hours, a month thing is something that certainly the PA Clinical Network would be willing to consider and doing that. But at least if I'm hearing you correctly, right now today, without question, you can employ the physicians and the physician immediate families in our practices. And as we discussed, most of our practices are smaller. There are 2 doctors, there's 3 doctors, there, the non-physician providers or the mid-levels, like a nurse practitioner or a PA, would not be eligible in that arrangement.
Again, that's only when I say it's a business decision, by that you're talking to the physician.
Right. I mean, just because of the reinsurance and everything else.
We could. Like I said, it really was more that we wanted to be very clean in our messaging, that we are really for physicians first, right? Because we really want to target that professional population. I really want to extend this. I've had associations of nurse practitioners and PAs. I've had associations of dental networks, right? And like I said, even chiropractors, right, come through and say, can we have this? And it's really just whether we as Ryze are ready to extend into those other professional circles, right? We do consider them our colleagues, and I would love to. I just haven't done the work to figure out how we can extend it into them. However, if we're talking about our partnership with Pennsylvania Clinical Network, and you say, hey, we have a small practice, it's just me, one other physician partner, and we have 2 NPs. Okay, yeah, I think we can include them. That's not a problem. Right now, some of these other bigger groups
I'm not trying to put you on the spot or doing.
No, not at all.
To get some clarity for what we can advertise right now to our network. This is a recorded. Other members in our network that are not here, their questions will necessarily come to Keith or to me. And I wanted to say, listen, without question, you as a physician and your family can get coverage tomorrow through Ryze in doing this. Other members of your staff, not an easy answer. I can't give you that answer myself. There are things in the works to cover that. As you know, we as a network are not all the same tax ID. We're a bunch of independent practices in there. I think that's similar to Lisa too. And again, the connection here with Michael is another physician leader in the New York area that I connected with. She mentioned Michael and Ryze, and that's why we're talking today. And we did talk further. Keith, next steps, we know this is available. We know this is something I think that at least, and each practice, like with everything, will do their own homework and decide. We're not mandating health coverage, but we do want to be able to provide it. And we do know that this is one of the biggest pain points, as you probably see, Michael, not only in Pennsylvania, but across the country. Irony of ironies, physicians and physician offices having trouble getting health insurance for themselves and their families.
Yep. Or physicians like myself, I worked for IU for a long time because unfortunately, my wife did have some medical issues, and it was really a concern, right? I was like, it's not even really the traditional golden handcuffs that previous generations of doctors had. I can't believe health insurance is a golden handcuff of why I worked for an additional 3-4 years for a big corporate academic hospital. I didn't even love the job towards the end anymore, like burnout. But I worked an extra 3 years just because it provided health coverage, right, for my wife, and that shouldn't be the decision. Health benefits should not be a factor in your decision to start your own business. Let's put it that way, right? Like that. It's fine if you love working for the hospital. I have colleagues who are very happy in their jobs, but if they wanted to leave, health benefits should not be one of those reasons, right? You don't stay at work at the hospital because they offer great car insurance, right? Like you can get that anywhere. So so that's what we're hoping to do, is to really, I like to use the word democratize. I really want to democratize health insurance so that it is like car insurance, right? You can get car insurance, very affordable car insurance, without being a part of a big corporate employer. I'm trying to figure out how to do that for health plans as well. But yes, one of the things I love about this potential partnership, guys, is that we are small, right? So we are willing to be flexible. So when we say, hey, what about the nurse practitioner network? Like, I don't know much about the practices you have. I think you guys have roughly about 50 to 70, I think you said, independent practices. One
Correct.
thing we could do, right, as an exploration is to say, well, let's look at the size of those practices, right? You mentioned they tend to be small. Well, how big are they? And how many of them are NPs versus nursing staff, right? If I have some of that data, or we do this too for medical societies and other employers, is that we have a tool platform where we can collect the census information, right? We can collect the information about the staff, whether they're NPs, physicians, or nurses, or the front desk, like, or office managers. Doesn't really matter, right? We can collect that information, and then we can give you a better insight to say, what does your population really look like from an insurance need perspective, right? And how can we launch certain parts of Ryze so that, yes, physicians can come on tomorrow, but if we really want to tackle nurse practitioners, even though we're not out there marketing saying we're covering nurse practitioners right now, because we would get an influx of requests that we wouldn't necessarily want to handle just yet, right? But if with you guys as a partner, we might say, well, look, if there's a certain number of NPs and PAs we can see across your many clinics, and we make the decision saying, yeah, let's bring those in as part of the group, we could do that, right? So again, like this isn't where there's a regulation stopping me. It's more just, I don't have much insight into what your population looks like yet, so it's hard for me to say, yes, let's take on the nurse practitioners immediately. But we could work together towards that end.
Sure. No, understood. Understood. And again, I'm looking for the defined edges, or the black and white, where I can say definitely that's it. And if a doc wants to sign up, and again, creatively, that physician within his practice can offer stipend, like you said, or something else, so that their employees can get something otherwise. So
Yep. Yep. And remember, like, the power of what you guys have is very similar to what Lisa has in New York. You're already a network. You're servicing other insurance companies, right, for their patients. I'm just saying, when your own employees or family members become a patient, you shouldn't have to pay Blue Cross just to come back to you, right? Like that. It never made sense to me how I was Blue Cross in Indiana, and it didn't make sense how I could be told as a patient consumer that my premium's going up, and then at the same time as the provider for the same Blue Cross that my reimbursement's going down, right?
Right.
Like that didn't make any sense to me. So if you're a network, just think of us as being a layer on top of that, so that your members can actually see each other now and be paid much faster and better, right? So it is really like Mayo, where they're basically taking care of their own, as an analogy. So, but yeah, look, guys, let me know how we can work with you. I'm actually very interested in figuring out how we can work with you guys, whether you guys love our insurance or not. I would love to have PA Clinical Network as a provider for Ryze, right, in Pennsylvania. So
right.
I think there's
and that's another definite that's immediately available. Somebody that
yes
and again, it's totally detached. You don't have to be subscribed to your health insurance as an individual, but if you wanted to be a Ryze health provider in your network or participant, you can do that also at any time. Now, as you said, it really makes sense with the organic growth, because as individuals insured, we would seek care, amongst our physician community, and that's how then the Ryze name would get out there, and this and that. Well, you or your family is seeing this specialist or somebody else like that. Oh, you don't take Ryze? Well, you should. It pays better, first of all, and then it grows that way. So, okay.
Yeah. Well, thank you guys for your time. I really appreciate it. I'm happy to take on additional questions if there are folks I need to leave. certainly do so. I can stay on a little bit longer if there are folks that wanted to talk a little bit longer, or happy to just have additional calls with the team to answer any additional questions that you may think of. Happy to visit as well. If it helps to be in person with the committee to discuss things in more in detail, I'd love to bring a couple of my other co-founders and partners to that meeting so we can iron out some details. Happy to do that as well, but just let me know.
Sure. I know that you and I will be talking more regardless of this, and
Appreciate that.
this is recorded. We will circulate and advertise that. Other questions may generate it, and from that, and we may ping you between and just say, here's a great question, this and that, and make sure that we can get those answered sooner rather than later.
Okay.
There, but again, I think philosophically, all the reasons that you are doing this and starting your companies, all the reasons that we as a PA Clinical Network are in existence. We're helping doctors remain in their setting of choice, and independent, and not be beholden to do that, and make sure that even young doctors coming out recognize that there is a choice.
Yep. And I hope our other states initiatives will also help synchronize with what you guys are doing in Pennsylvania, right? So as we bring on networks in other states, that's what the power of the whole, when I had that slide say we're trying to expand the network, right? Imagine your doctor traveling to Georgia and that's still in network, because those are all going to be Ryze physicians anyway. So instead of Mayo only being in, where Mayo is physically located, we could be in every single state, right? So in every single state that you happen to travel to or relocate to, or doing locum stat or contracting across state lines, there would be a network there to service you and your family's needs. All right. Well, I've said quite a bit. Thank you again for your patience, and thank you for your questions. And please keep them coming. And I love to continue the exploration.
Great. Thanks, Michael.
Thank you, everybody, for your time. Have a great evening. Thank you.
Good night,
Thanks,
everybody.
everyone.
Bye.
Bye-bye.